Hello, everybody, and welcome to today's webinar. We're going to be talking about the updates to the CCBHC certification criteria. I see a few people have already kind of chimed in the chat, and I wanted to start with some housekeeping, including it looks like, unfortunately, we didn't realize that we'd be capped at 500 people for this webinar, and it looks like we are hitting that cap, and so unfortunately, that means that probably some folks aren't going to be able to access today. We are going to be recording this, and we're going to be posting the slides, and so we'll make this available so other people can see it. Hoping that this will be available to other people. Sorry about that cap, and I hope that doesn't prevent anybody from getting any information that they're interested in. The second kind of piece of housekeeping is we are going to be recording this today. Obviously, if we're providing a recording, so just know that you're being recorded, and so if you have an issue with that, you can drop off, and you could of course watch the recording later. The final piece of housekeeping: we are going to be taking questions at the end. I don't think the presentation is going to take a significant portion of the time. I'm going to provide a kind of a broad overview, and then we'll take questions at the end. You can either ask questions by putting them into the chat, or you can raise your hand, and we'll try and unmute you so you can ask your question verbally. But that being said, I wanted to start by thanking you all for your participation in this process. It's I think an important process, and I appreciate your attention. We've been lucky to get a lot of really great feedback, which I think have informed the development of the criteria so far, we're looking forward to getting more feedback on this draft of the criteria that we released at the end of the last calendar year. But I appreciate all of your time. I know that you're all busy people, and so it means a lot to us that we are at capacity. So next slide, please. So today I'm going to give you a little bit of background and history. I'm going to talk a little bit about the reasons for the criteria update. I'm going to talk about our timelines for the CCBHC initiative / criteria updates. And then I'm going to go into the detail of what the updates in the criteria entail. They're broken out into kind of three major groups: significant updates to advance the field, other revisions, and then the updated quality measures. And then I'm going to talk a little bit at the end about how to submit feedback on the draft of the revised certification criteria. Next slide, please. And so you may have seen this slide before. We use it a lot, but I wanted to start by grounding us in the current criteria. And so this is the structure of the certification criteria. There's 6 main areas of the criteria, and then there's 9 required services. This structure is not changing, is being maintained from the previous criteria to the current criteria. And so the criteria broadly still look the same. There are a number of updates that are in the details, which we'll get into. But just wanted to reiterate that the broad structure of the criteria is going to be the same. There's still 6 program requirements. You'll see those on the left side of the screen. And those are staffing. The criteria includes standards around staffing informed by a local needs assessment. There's requirements around the availability and accessibility of services in terms of timely access to services, outreach and engagement, access to crisis services, and treatment planning, and acceptance of all clients regardless of their ability to pay or place of residence. There's requirements around care coordination, including requirements around health information technology and electronic health records. There are, of course, the 9 required services that I mentioned on the right side of the screen, and those remain the same. So crisis services, screening assessment, diagnosis and risk assessment, outpatient primary care screening and monitoring, treatment planning, outpatient mental health and substance use services, targeted case management, peer family support and counselor services, psychiatric rehabilitation services, and then community-based mental health care for veterans. There's requirements around quality and other reporting. So still there's a set of quality measures that all CCBHCs in the Section 223 Medicaid demonstration are required to report on. And then all CCBHCs are required to have quality improvement activities. And finally, there's requirements around organizational authority and governance. So CCBHCs are required to have representation among the people they serve in governance and among people with lived experience. And then they're also required to have appropriate state accreditation. And the current criteria, that is the criteria that are currently being used in the field, are available on our website right now. So you can look at the current criteria The link is at the bottom of the screen here, and you can compare that to the updated criteria, and we'll be sharing a link where you can find the updated criteria at the end of today's presentation. Next slide, please. So I want to talk a little bit about the history of the CCBHC initiative. So CCBHCs really came to life in 2014 when they were authorized through the Protecting Access to Medicare Act. In 2015, the federal partners, which include the Centers for Medicare and Medicaid Services, the Office of the Assistant Secretary for Planning and Evaluation, and then us here at the Substance Abuse and Mental Health Services Administration, released the original certification criteria and the prospective payment guidance. And then we awarded 24 state planning grants to join the Medicaid demonstration. In 2016, we selected 8 states to participate in that Section 223 Medicaid demonstration. The states are listed here on the slide. And then in 2018, and this was after the criteria were developed, an important note, the original criteria were developed with only the Medicaid demonstration in mind. Those are the criteria that we're using right now. A new way of supporting CCBHCs was developed by the federal government, which is that we received appropriations to create CCBHC expansion grants, which are grants that support the CCBHC model using grant funding from SAMHSA. In 2020 and 21, we added 2 more states to the demonstration, Kentucky and Michigan, as a result of the CARES Act. In 2022, really big development, exciting development for us this past summer, the Bipartisan Safer Communities Act authorized an addition of 10 states to the demonstration every 2 years starting in 2024. And so we're in the thick of that process right now. Shortly in March of 2023, we should be awarding 15 planning grants, and we're hoping to release the updated certification criteria ahead of awarding those grants. We just received the applications from the states that put in applications for that at the end of the last calendar year, so end of December. And we're really happy to have a strong group of applicants, and so looking forward to awarding a strong group of states that participate in those planning grant opportunities. In 2024, as I said, we're going to be adding an additional 10 states to the demonstration. And then our instructions currently in legislation is that we're supposed to add 10 additional states every 2 years thereafter. Eventually, we are going to run out of states, but I think we have plans in place for this cohort where we'll be awarding in 2024, and I think another cohort at least in 2026 at a minimum. Next slide, please. So why are we doing this? You may say, this seems like a lot of work, and it could certainly shake up things for existing CCBHCs. And we've been considering updates to the criteria for some time. There are a number of areas where we think there could be improvements to the criteria, and the passage of the Bipartisan Safer Communities Act and the imminent addition of new states made this more urgent. We kind of came to the realization that if we were going to update the criteria, it wouldn't make sense to add new states to the CCBHC demonstration and have them, come in under the old criteria and then have to adjust their plans early in their demonstration programs to adjust to new criteria. And so that kind of spurred us along to make these criteria updates ahead of the awarding of those state planning grants. We now have several years of working with the CCBHC model, and we really like the model. We think it's a very strong model. We're pleased with the results. We've seen kind of, I think, good reception in the field around the CCBHC model. But there's several areas of the criteria that do need to be updated. First, we want to respond to developments in the field. There's changes in terminology in the field, and I think that's important. Before, all the work that's been happened around the 988 suicide and crisis line and the development of crisis systems, a lot of that work has happened after the criteria were released. So the criteria really don't address that work. There's a number of emerging best practices in the field that aren't reflected in the criteria. There are workforce shortages in the field. We would like to respond to those by providing flexibilities in some areas. There's areas of the current criteria that are no longer current. So the criteria, for example, reference electronic health record standards under ONC that haven't existed since 2016. And so, so those are out of date, and those have been updated in the newer version, the proposed draft of the revision of the criteria. And then we've had lots of suggestions from CCBHCs, from states, from other stakeholders about ways that we can improve the criteria. And so these are increasing a focus in areas related to substance use disorders and social determinants of health. But we've had a lot of really good suggestions about how we can improve CCBHCs. Again, sticking with the framework, there's a broad similarity between the existing criteria and the new criteria, but we did identify a number of areas where we think that we can make improvements and make this work better for states, providers, and ultimately result in better care and support for the people served through CCBHCs. Next slide, please. So I want to walk you through the criteria update timeline, and this is the timeline for updating the criteria. So the Bipartisan Safer Communities Act was signed in late June. In August, we made the decision and the public announcement that we were going to be updating the criteria. In November, we went through a series of activities around soliciting input from the public. We held listening sessions with a number of groups. You can see those groups listed on the right side of the screen here. We held a webinar introducing certification criteria update process. We had a 4-hour listening session open to the general public on November 17th. We got a number of comments through email to the CCBHC criteria at samhsa.hhs.gov email box, which informs the updates to the criteria. And so we took all that feedback, and that in large part was what informed the updates to the draft criteria that we've released. We posted the draft criteria for public comment on our website on December 25th. Today, of course, January 5th, we're holding this webinar to the field to provide an overview of the draft updates. We are hoping for public comment on those updates by January 20th. So that's your deadline, end of the day, January 20th, to provide written comments on the criteria. Again, that's to that same email box, which we'll have at the end of the presentation, but it is CCBHC criteria at samhsa.hhs.gov. And so our goal is to get these criteria posted, the updated criteria, incorporate any revisions based on public feedback before the award of the new state planning grants, and the plan is to award those in March. And so that's kind of our rough timeline for when we'd like to get these out in the world. And then we will have a final overview shortly after we release the final criteria to provide updates and just provide an overview of what is included in the final version of the criteria once they are released. Next slide, please. So I want to talk a little bit about the structure of the document that's posted on our website. And so it's got an introduction with a little bit of background and information and history about the initiative. It is structured the same as the last set of the criteria, and so around the 6 program requirements, which are listed here. So the criteria really run through all those requirements. There's an appendix, Appendix A, terms and definitions, and I think this is an important appendix for folks to look at, because some of these terms and definitions include detail that really is important to how CCBHCs are run. For instance, we provide, kind of detail around the community needs assessment, around, different aspects such as primary care screening and monitoring. And so this is important to look at. Sometimes I know when you read a long document, the temptation is to not look at the terms and definitions or the glossary, but I really would encourage you all to take a look at that if you can. So the next appendix is the behavioral health clinic quality measures. And so these are the quality measures that CCBHCs in the Medicaid demonstration are required to report on, in states in the Medicaid demonstration as well. And we are making updates to those. And so the new version of the quality measures is included in Appendix B. And right now, we aren't asking that CCBHC expansion grants report on the quality measures. That is something we are considering. So if you are an expansion grant, you should take a look at those. The state level measures obviously can't be reported at the clinic level, but the clinic level measures may someday apply to you. So if you're an expansion grant, I think it is probably a good idea for you to take a look at those clinic level quality measures. And then finally, I think this is an important appendix for you folks who are looking at these criteria and trying to figure out what we revised. We do have a summary of the changes that we've made in Appendix C, including kind of references to where we've made changes in the criteria. And so if you have specific areas that you're interested in, I think probably flipping through or reading through that appendix quickly will give you a sense of the broad scope of the changes, and then also enable you to go back and see where we've made changes in the criteria based on the references there. Next slide, please. So these are some of the areas that we've made revisions to the criteria. There's 3 broad areas that we felt were really important that we made revisions around crisis care, around substance use disorders and responding to the overdose epidemic, and then also around health equity. We've added detail around each of those areas to try and strengthen the criteria. And then there's been other revisions we've made as well. And so there's needed structural changes to the criteria we've made, such as, there's changes to increase flexibility or reduce the burden of implementing the CCBHC model in areas that we don't think will weaken the model. There's additions that we believe will strengthen the model in several areas. There's updated language and examples included in the criteria, and there's some areas where we clarify the language. And then, of course, there's the updated quality measures that I mentioned. So, next slide, please. So just want to talk about the significant updates to advance the field. And I should say I'm going to go through at a very, very broad level some of the updates we made to the criteria now, but this doesn't really capture the full sweep of all the changes we've made. You really have to go through and look at the criteria in Appendix C to understand the broader set of changes we made to the criteria. But I try to kind of hit some of the high notes on these slides and in my presentation today. So one of the first major areas we decided to make changes to the criteria or proposed changes to the criteria is around crisis care. There's been a lot of work in the field around, as I said, the 988 Suicide and Crisis Lifeline. We are requiring coordination with those entities that are part of the Lifeline with CCBHCs. They should be coordinating with the 988 Calls Crisis Center that is serving their area. That's included in several places in the criteria. We've updated the crisis service requirements to align more closely with SAMHSA's national crisis guidelines, including coordination with area air traffic crisis control. So the requirements CCBHCs have some capacity for urgent care / crisis walk-in. And then aligning with the mobile crisis guidelines in the criteria with requirements that SAMHSA has in place in our guidelines, and then also with some of what Medicaid has put in place through their work around mobile crisis. In order to respond to the continuing overdose epidemic, we've placed a stronger focus on addiction and substance use disorder in several places. We've included a requirement around having addiction medicine staffing or consultation in place. We've placed a stronger emphasis on the ability to prescribe buprenorphine and coordinate with opioid treatment programs. And that's if you're not an opioid treatment program already, some CCBHCs are. And then that only also applies if there is an opioid treatment program in the service area of the CCBHC. We don't expect CCBHCs to coordinate with OTPs that are outside of their service area. We've added provisions throughout to strengthen the ability to address overdose risk. We've done that in similar ways that we've asked the CCBHC already to respond to suicide risk. We've included the requirement to provide intensive outpatient services programs for substance use disorder. We've added a focus on harm reduction and on using motivational techniques. And we require that quality improvement plans address fatal and non-fatal overdoses as in the same way that they're currently required to address suicide. We've added some areas around health equity. We've aligned the training requirements with the National Cultural and Linguistically Appropriate Services Standards, and that's the CLAS standards, as maybe how you've heard of those. We've included a stronger focus on outreach to underserved populations as a required activity. We've included a stronger focus on social determinants of health and community and social supports in the requirements around comprehensive diagnostic and treatment plan evaluation. We've required that the quality improvement plans have an explicit focus on people and populations experiencing health disparities, and that CCBHCs disaggregate their data to track and improve outcomes for populations facing health disparities. Next slide, please. There's other revisions in addition to those 3 main areas that I've provided an overview of already. We've, as I mentioned before, we've updated the guidance around electronic health records and health information technology requirements. We've changed requirements related to designated collaborating organizations and provision of the 9 core services. Through some examination of the statute, we've determined that it's not something we can do to require that the 4 core services that existed in the criteria before be provided directly by the CCBHC. So we removed that requirement. TCOs can provide any of the 9 services, but we still believe that it's very important that CCBHCs provide coordinated care and not fragmented care. That's actually one of the core reasons why CCBHCs exist. And so we added some other provisions to make sure that continues to be the case. So we're requiring that CCBHCs be Medicaid providers of both mental health and substance use disorder services. We require that CCBHCs directly deliver the majority of services across all the 9 services. And what we say there is by the volume of services provided. So not 5 of the 9 services, but the total volume of the services delivered. We expect that CCBHCs deliver the majority of the services and by volume. We've adapted the criteria to apply to the CCBHC expansion grants in addition to the Medicaid demonstration, which is something that I mentioned earlier. The existing criteria that we're using right now really aren't adapted well to the existing CCBHC expansion grant program outside of the Medicaid demonstration. We've also tried to increase the flexibility of the model and reduce burden of the model. So we've increased flexibility for the medical director position for CCBHCs that are unable to recruit a psychiatrist outside of health professional shortage areas. We've relaxed the requirement for primary care involvement in treatment planning. We've relaxed the treatment plan update frequency requirements. Previously, it was every 90 days, and that was something we heard from a lot of clinics that was very difficult. So that's been relaxed to once every 6 months. We've relaxed requirements for care coordination agreements. In the existing criteria, there's a lot of agreements. There's a lot of requirements that CCBHCs have to establish agreements, written formal agreements with other community partners. What we found is that a lot of CCBHCs may put in their best effort to create those partnerships, but the people on the other end aren't always willing to sign those. And so we've taken a new approach where we require CCBHCs to try to establish those partnerships. But if they can't get that signature, they have to document that and do what they can to either create unsigned, jointly developed protocols, or to demonstrate what they're doing on their side, on the CCBHC side, to support care coordination, and then to continue to try and develop those agreements. We've also provided flexibility in the depth of the assessment that CCBHCs have to do, the required assessment based on clinical judgment. Just to make it clear that CCBHCs don't have to do the full, comprehensive, in-depth evaluation for everybody. They should touch on all the required areas, but they can use their clinical judgment and decide how much depth they need to go to in any given area, depending on the client they're serving. Next slide, please. So we've also made some changes to strengthen the model in areas we felt were important. So we provided some clear guidance around what's included in the community needs assessment. And that's one of those areas that is not just in the body of the criteria itself, but also in Appendix A, terms and definitions. We've included a stronger focus on shared decision-making and client preferences throughout the document. We've added a requirement around assisting clients to access benefits and enroll in programs such as Medicaid. We've added additional detail around outpatient service requirements. We've increased the specificity around primary care screening and monitoring, including the requirement to screen for HIV and viral hepatitis for populations where that is appropriate. We required provisions for supports around employment and education, housing, and then social inclusion in the psychiatric rehabilitation required service. And we've recommended the use of measurement-based care as a part of the quality improvement processes. We've also updated language throughout the CCBHC criteria in a number of places. So we've replaced the word consumer with the word client. We've stopped using the word detoxification and replaced it with withdrawal management. We are no longer using the term medication-assisted treatment. Instead, we've moved to medications for opioid use disorder, alcohol use disorder, and tobacco use disorder. And we've also tried to update our language around peers to make sure we're being inclusive across the field. We've also tried to clarify our language in a number of areas. So we've provided clarification around what should be included in the comprehensive screening and assessment. We've clarified our definition of targeted case management and are recommending implementing intensive support similar to assertive community treatment, not a requirement, but a recommendation. We've clarified requirements related to the representation of people with lived experience and family members in governance, which has been an area where we've had lots of questions in the past. We've also made minor changes to reflect clarification, the original clarification throughout in areas where stakeholders have addressed ambiguities. Yeah, next slide, please. So we've also made updates to the quality measures. These are the required quality measures that are currently used in the Medicaid demonstration or the 223 demonstration. So we are proposing 5. These are the required measures that you see on the right side of the screen. There are also optional measures that CCBHCs can use, but these are now going to be the required set of measures. We're proposing 5 clinic collected measures and 13 state collected measures. And that's a change from the 9 clinic reported measures and the 12 state reported measures that were have been included in the CCBHC criteria to date. As you're looking at the right side of the screen, you can see the list of measures. The ones highlighted in green are either new measures or measures that have been significantly expanded in this version. You can see it here, but we've tried to strengthen the focus on time to services through these new measures, on crisis response, on social determinants of health, and then on medications for opioid use disorder. We are also going to be throughout using updated technical specifications that were now out of date for the existing CCBHC measures and the specifications that are posted on the SAMHSA website right now. So we're updating to use the most recent specifications across the quality measures. And then we are removing and making optional some of the existing quality measures that have been problematic. And this is, we're hoping, going to balance out the burden created by the new measures. All right, next slide, please. So we're asking that you submit any feedback on the CCBHC draft revised criteria to ccbhccriteria@samhsa.hhss.gov before the end of the day on January 20th, 2023, coming up in a couple of weeks. And you can find information about the CCBHC criteria update process at the link at the top of the screen here. And we're going to be posting information updates about the process there. You can find the draft revised criteria there. You can find, I think that's where we're going to be posting this webinar, and there's other resources there as well. So, please check out that page for updates. We'll also try and keep the e-blasts and other things moving as we move through the process. Next slide, please. And so now it's time to get to questions. And but before you do that, I did want to say thank you to a few people who really helped us get where we are today. First, I wanted to reiterate thank you so much to those of you that have participated in the process so far. Your feedback was invaluable in crafting this draft set of revised criteria. Really appreciate it. Whether you're working at the state level, at the clinic level, whether you're a stakeholder or an advocate. I know you're all very busy, especially in the current environment and the current workforce environment. And that you took time out to do this really means a lot to us. So thank you. Secondarily, I want to thank our federal partners. We were lucky to get, we've had great engagement and great partnership with CMS and the Office of the Assistant Secretary for Planning and Evaluation throughout the process, but they've been great through the criteria update process. But we've also been lucky to have support from other partners internal to SAMHSA. People across SAMHSA really weighed in on these criteria. We really appreciate that. I want to thank our CCBHC team. There's a number of people who worked really hard for the last couple months on this, and I have a feeling we have another busy month coming up in February as we try and work in all the input I'm sure we'll be receiving in January 20th. And then I really want to thank 2 people who have really thrown their weight behind this. We are lucky to have support from Westat on this project, and Shoma Ghosh and David Morissette are 2 people who've just put an enormous amount of time before the holidays in making these come together. So I want to thank all those folks, and it's not over yet, so thanks for the work that's coming up too. But with that, I'll turn it over. We'll move over to questions, and again, I'll try and go through some of the questions in the chat. But if folks want to raise their hands, I will try and also get to some questions from that people can. Once you raise your hand, I'll recognize you, and I think the folks who are helping doing this webinar can unmute you so you can ask your questions. So, all right. Well, why don't we start with some of the raised hands, and then I'll go to the chat after that. So, Sean, you want to? Let's see. I think I can even unmute.
I can unmute. I'm good.
All right, great.
David, thanks for everyone's hard work on this. I know there were a lot of inputs to filter through. So want to say thanks. I had a specific question arise around 4G1 to 4G3. A lot of clinics in our state may do like the draws for different testings, but send those out to another lab to be done. And the way that it's worded makes it seem like that they would need to have a DCO in order to do that.
Okay.
And so I think the intent was for them to be able to draw it and offer those services. But there was some questions from our centers as to whether or not they would have to enter into some type of arrangement with another entity in order to have those processed, or if their existing like Quest would be enough.
No, that's a great comment. We can take a look at that. You know, I certainly don't want people to try and enter into a DCO with LabCorp or whatever. So,
right.
Yeah, no, that's a great comment. Thank you for that. Let's see. I'll take one more question, Amy, and then try to get to some questions in the chat. So, Amy Jones, I think you may be unmuted.
Yeah, thanks. I'm with Amy Jones. This is Jess Bounds. I had a question in regards to 4I1. It talks about that services are more clearly defined and require the provision of supported employment of services, etc. Is supported employment going to be a covered service now?
So states had the option before of including supported employment as a part of the required evidence-based practices in their demonstration projects. But we're now moving to have supported employment be a required service for CCBHCs. Or that's what we're proposing anyway. So.
Thank you.
All right. I'm going to go to a couple questions in the chat. So I see here, will there be a phase-in period permitted for existing CCBHCs that are part of the demonstration to implement any changes in the new criteria? Yes, absolutely. So I think we're looking at what the reasonable time frame is for phase-in for expansion grants, for clinics that are part of the demonstration. And then, you know, we're also working on the guidance for adding additional sites to the demonstration. And so we're trying to figure out the timeline there for how that interacts with these new criteria. But our goal is to make it, you know, a reasonable implementation timeline that gives clinics and states, you know, ample time to come into compliance with the new criteria. That's our goal in doing that. There's a question here that there was already a NOFO released a few months ago in October for the state planning grants. Oh, sorry, I think this is a question about the expansion grants. It does look like we're probably going to be doing a notice of funding opportunity for another round of the expansion grants, the PDI, planning, development, and implementation grants later this year. For the social determinants of health editions, will you require or recommend a specific SDOH assessment? You know, we are going to provide further detail around those quality measures, you know, moving forward. And actually, I should have mentioned that on that slide I meant to, but we're going to be doing a member of our staff or our team who's worked really hard on this. Peggy O'Brien is going to be doing a series of webinars to around the quality measures. And then we are going to be also working that into our technical assistance moving forward as we build out our technical assistance capacity. There's a question here about 988 crisis centers in the state. Yeah, we realize that you know, this may be something as 988 centers are developing capacity that can be an issue, but you know, we are putting a lot of resources into the 988 system. You know, I think what we're asking for is coordination with those 988 centers, and we really think that's important. We don't want to create a parallel crisis response system that operates separate from 988 with the CCBHCs. We want these to work together, and so if there's suggestions you have around, you know, coordination with the 988 centers, how to make that work better, we certainly would be open to it. But we do think it's really important that we be coordinating across 988 and the CCBHC initiative. But you know, would welcome your concerns in that area. So a lot of CCBHCs have their own crisis lines, or they have their own lines for clients to call into, and that's perfectly fine. I think we're just also asking that you coordinate with 988. Air traffic control question mark. Yeah, that's a term of art from the crisis guidelines that SAMHSA developed. It's basically the system for tracking when a crisis call comes in and making sure that there's a response and tracking the status of that response in real time to make sure that people are getting the support that they need while they're experiencing a mental health crisis or a substance use disorder crisis. The detail is included in the criteria. Will we be updating the CCBHC attestation spreadsheet with these revisions? Yeah, we'll be providing kind of a summary sheet of the updated criteria once they're finalized. Is there a reimbursement for focusing on SDOH, social determinants of health screening? For expansion grants, a lot of the areas covered in the SDOH measures are probably already covered through our national outcome measures. For states that are for clinics that are in the demonstration, I think this is something that we can look at how this works with the PPS. But that's a great question. All right, I'm going to go back to if folks want to raise their hand, I'm going to try and go back to the. I'll try and squeeze in a couple more questions while people are raising their hands. Is there a requirement for the states to conduct a needs assessment, or is the responsibility of the candidate CCBHCs to perform the initial needs assessment under direction of the state moving forward? So CCBHC expansion grants are going to be required to conduct the needs assessment independently. When there are states, they're responsible for making sure that CCBHCs in their demonstration program are meeting the criteria, and so they should be working with their states, their clinics to do that needs assessment. All right. I see. Amy, is that a new hand, or is that I'll just ask to unmute and then tell me if it's a new hand or not.
Hi, it's Jess again. New question, same hand.
Sure.
Or, I don't know. Yeah. So, in regards to the crisis criteria outlined, I'm just curious. I also put it in the chat. So if providers have the ability then to refer to 988 for both crisis line and mobile, what is the purpose or incentive for them to maintain their own crisis line and or mobile? Like, what's the?
Well, we need to make sure that so I think the responsibility of the CCBHC is to make sure that they have 24/7 ability to provide crisis response. And so they don't necessarily have to have like a full crisis line, but if someone calls the CCBHC and they're in the crisis, the CCBHC needs to be able to respond and either directly respond to or through a DCO relationship, provide that mobile crisis response. Does that make sense?
Yeah, so you're saying if like I were to call the CCBHO directly, they need to be able to respond or have a DCO able to respond versus like just referring me to 988?
Right.
Thank you, sir.
And I think, ideally, you could think of a world where once there's the coordination between 988 centers and 988 crisis centers and CCBHCs, the 988 system is going to work a lot better if we have robust crisis response. And, I think we'd like to see a system where, if there's a 988 call center and they know that they're, that there's a CCBHC in the area that the caller is from, they can then connect them with the CCBHC to provide that mobile crisis response. So, of course, that's very different across different areas. But there's a question here: are there any existing CCBHCs that are OTPs? I wasn't aware of that. Yes, there's a handful of CCBHCs that are already existing. There are also opioid treatment programs. So let's see, Lindsay Ragona. Let's see, I think you're unmuted now.
Hi, thanks everybody. Thank you so much. This is really helpful. Simple question. I know that you guys said that the recording and the slide deck would be available. I'm just wondering what the time frame for that would be so I can tell everybody to look out for it.
That's a great question. We'll work with our web folks to try and get it up in the next couple of days,
Okay.
and I hope that's possible. If you're not seeing it, feel free to email that mailbox, and we'll try and see what we can do to get it to you. So.
Okay, great. Thank you so much.
All right. All right, Natalie. Let's see, I'm gonna unmute you, I think.
Hi, David.
Hey.
So my question is around the laboratory testing. I just want to make sure, am I reading it correctly that CCBHCs will be required to directly provide laboratory testing?
I think the idea is that there's some chronic and physical health conditions that are commonly experienced in the among the populations being served by CCBHCs, and really to do ongoing monitoring of that, they'd have the capacity to do some of that. And so I realized that there was the earlier comment about being able to send out labs, and so I think if you have some suggested language requirements or changes that would make that more feasible, we'd appreciate it. And then also if you say, look, this is completely unreasonable, there's no way we could do blood draws, that's also good feedback.
Okay. Thank you.
All right. Okay. Hannah Carey, I'm gonna unmute you.
Hi there, thanks so much. Just a question going back to the 988 and the crisis services. If our DCO for our crisis services is connected with 988 already, would that suffice? Would we show that connection, or would we have to be connected directly to 988?
So I'd refer you to the wording of the criteria. There's kind of language in the criteria around the kind of specific kind of agreement that we'd like you to try and get with the 988 call center. That's where I'd direct you. So I hope that's clear. And if you have any questions after looking at that in that section, feel free to send a question or comment to the CCBHC criteria mailbox.
Okay, thanks.
All right, Andrea Kubrick, and I apologize for all the mispronunciations.
You're fine. Everyone mispronounces it, so you're good. One of my questions is with 988 again. So one of the issues I have had some coordination calls with the center that serves ours, and like most people on here, we do have our own local crisis hotline. One of the issues that we're having with 988 is that we're not getting reports on who's calling in or any referrals. And that's one thing that I've spoken to with them. They have tools in place where they could identify who's open to what center, like the care system, things like that. And that's where I'm wondering, like with coordinating, is there any accountability piece on both ends to where we can ensure that that's going to happen if those tools are there and available to be used?
I think that's a great question. And, that's something we can take back to our 988 team at SAMHSA. But I think, that's one reason for creating the agreements with the 988 system is if you can draw it into a signed agreement, that's a way of kind of trying to develop some kind of better assurance of what data might be available. But we run into this issue with hospitals and emergency departments and in other areas too, where there's definitely data out in the world that we'd love to have in the CCBHCs or get the CCBHCs access to, but it is a little bit outside of the control of the CCBHC. So we tried to encourage that where it's possible, but not make it an absolute requirement in the criteria. So there's a comment here from Andy Hinson about the term client, and we did get some feedback on this in the last round, and we struggled a little bit because we completely think that language is very important. And I know that there's some perception out there that client has a connotation of being in it creates an imbalance in power with the provider. Well, we recognize that this is also a legal document, and and we were trying to use and the word client has very specific meaning throughout the document. And when we got into trying to think of a phrase that would work, it has to include perhaps even family members in some places, and if there is better language, we would love to have it. Please submit comments. We realize that there's perhaps not a perfect solution there, and so we certainly want to empower people receiving services, and it does get a little unwieldy sometimes in trying to create a document that has kind of legal implications, or so if you have kind of a better term, we'd love the input. Let's see. There's a question: is there a specific social determinants of health measure that SAMHSA is recommending CCBHCs use? Will we get further guidance about that soon? We are trying to look at standard measures that are used elsewhere in the field, just as a general principle, but specific to the SDOH measure. When will those updated specifications be posted on the SAMHSA website? That's I think about the measures. There's going to be a lot more information about the measures coming out over the next year. So please kind of stay tuned for that. There's a request to review the health equity changes one more time. Let's see if I can just run through those quickly. We're going to be updating our training requirements to align with the class standards, the nationally, culturally, and linguistically appropriate standards. We're going to include a stronger focus on outreach to underserved populations as a required activity. We've added a stronger focus on social determinants of health and community and social supports in the required comprehensive diagnostic and treatment planning evaluation. And then we require that the quality improvement plans, the pre-existing requirement around quality improvement plans, have an explicit focus on health disparities, including racial and ethnic groups and sexual and gender minorities, and that the CCBHCs disaggregate data and track and improve outcomes for the populations facing health disparities. So that's kind of a very broad level, but to see the specifics, you really have to get into the criteria. And there are references listed for where you can find those changes in the Appendix C. Let's see. All right, there's a few comments here around social determinants of health, and we definitely will take those into account. It doesn't hurt to send those also into our mailbox, but we'll take this chat transcript also and incorporate it into the materials we look at as we look at updates to the revisions to the criteria based on feedback on the public version of the measures. We are going to try and stay up to date with the most current specifications of the CCBHC measures. That's one of our goals. So there are 5 clinic measures now. That's down from the current 9 required clinic measures. The question in the chat around that. So there's a question here around tobacco, and we have kind of added detail around tobacco here. We haven't included a requirement on having a tobacco-free campus policy for the CCBHC. Certainly an interesting idea and something you can submit for consideration. We are going to try and post the recording and the slides again on our CCBHC update page, but you can also email the mailbox CCBHC criteria, samhsa.hhs.gov about that. Will there be more sessions like this? We are going to be doing a session after we release the criteria, in March, so hopefully that will provide an overview of the changes. Let's see, and then again, we're hoping to make this recording available. There's a question here: 4G1, will the requirement for screening HIV, hepatitis require clients receive any CCBHC services? Yes, but it would be clients for whom it's developmentally appropriate or it's indicated by the population. So we don't expect to be doing HIV testing on 6-year-olds. It would be doing it in a way that's in line with the recommendations of the U.S. Preventive Service Task Force. Which should make sure you're doing that with the populations it's appropriate for. Sean, I think you have a question in the chat and your hand up. So I'm gonna go to I'm gonna go back to the chat or where people have their hands raised, and I'm gonna unmute you, Sean, and then I'm gonna get to Jim and Natalie's questions after that.
Yeah, so I really have 2 questions. One was, you said that Amy asked a question about supported employment. In reading the revised criteria, you also talk about housing. So are you saying that basically supported housing is now a requirement for CCBHC?
I think we say supported employment and then housing supports. So the idea is that some housing supports would be provided, but the shape of that would be up to the CCBHC and I guess, of course, the state as they develop their CCBHC program. You know, there's just such a, you know, there's a continued and I think worsening housing crisis in the country. And then, you know, in addition, you know, CCBHCs are very likely to serve people who face housing challenges. And so I think it's an important piece, but there's a lot of flexibility built into that language about how it might be implemented. It's not, there's not a specified model.
Fair. And then the other question I had is a question that comes up to us a lot, and maybe other states have this, and we just haven't talked about it in Kansas, but for urgent, emergent, and routine needs, is there a way that we could get that defined?
Okay, yeah, and you know, it's you know, we certainly can go back and look at that as we look at this draft for the final. But if you have suggested language, that's always helpful too. You know, that
Sure.
makes, you know, takes the guesswork out a little bit for us. So I appreciate the issue.
Yeah.
All right, thanks, Sean. I appreciate it. All right, Jim.
Okay. Hi. I was only a couple minutes ago be able to get on the webinar because of your capacity limitations. So I apologize if this is already discussed and I missed it. Is a NOFA funding cycle, is NOFA going to be released this year? And if so, do you know when?
So I think we are probably going to be releasing a NOFO for the CCBHC expansion grants. We were fortunate in the appropriations bill to receive a $70 million increase in the appropriations for CCBHC expansion grants, and those are that's the line that funds the PDI and the IA expansion grants. And so we do anticipate there's going to be another NOFO this year. You know, I can't give you a date certain. It probably will come out. This is not going to be very helpful. Sometime, you know, before spring.
Sometime before spring. Okay.
Next few
and
months.
Will this be both types of grants, both for new grantees and for current grantees?
I believe so.
Okay, thank you.
And then Natalie.
Okay, so the measures question got me thinking of something. I noticed some of the new measures had stewards that I'd never heard of that were new, which kind of raised, which when we were meeting and talking about it, raised some concerns about pulling in measures from stewards that are not nationally known. So
I think if you look at those measures, even if they're measured stewards you aren't familiar with, those are generally measures that are included in the Medicaid core set or in other places in our kind of commonly used measures, even if it's a lesser known steward. And so I think they should be fairly well established. You know, we've tried to pick standard measures where we can, and then you know, measures that we think are not going to, you know, go away or fall out of use. Although we tried to do that last time too, and we had a couple that so we'll do our best. So.
we'll be on the lookout for the specs. But and then I also want to follow up with Sean's comment about definitions. I would rather not get definitions for urgent, emergent, routine. We've been operating since 2017, and you know, we're already dealing with a lot of changes. And so you know, the less prescriptive that I think that we get on at the national level gives providers a little more flexibility at the state level. And I know that as a state, we kind of appreciate that any flexibility that we can have at the state level. At least we do in Missouri. So
we definitely appreciate that. And we have tried to thread the needle. You know, there were a number of proposed changes we did not include in the criteria, you know, because we don't want to increase the burden or make this unworkable. And so, you know, and that's something I should say, you know, if there's something we proposed, or if there's something you like that we've proposed, you know, it's helpful to get comments. You know, sometimes people only point out the things that they don't like. And if there's something that you do like, please let us know, because, we might get comments saying that people don't like the changes, and then we'll pay attention to those comments without knowing that there were maybe some people out there that did like the changes. So it's helpful to hear both sides of some of these issues, to know that there's not, one set of opinions. So if you hear the conversation, you hear someone else raise a concern, you say, I don't necessarily agree with that, please make that known to us. You don't have to do it on the webinar. You can send it in by email. So thanks for being very polite about it also, Natalie. I know you know Sean also. It's all in the family. Anyway, all right. Okay, and then Kevin, we're right at time, so I think you get the last comment. And I'm sorry for folks we didn't get to in the chat. We will try and answer questions by email if we can. So send your questions in by email. So Kevin.
Yeah, this is real quick about the grants. If you were an expansion grant awardee but did not get awarded a continuation grant, so you have a gap in grant funding, this spring, would we apply for a continuation again or start over with a new expansion grant?
I think if you didn't get a continuation, if you, regardless of whether you've had a past award or not, unless it's an award that's continuing into the new grant period, and our NOFOs generally include who's not allowed to apply based on people who are in past grant awards. But generally, if you have a grant that's ended, you should be eligible to apply for another award.
Okay.
All right, well, I really appreciate the robust participation today. Really great comments and questions. Please send in your feedback to the mailbox. Contact us with questions. A number of you, we've conversed around this, so you can reach out to us directly too, and we'll try and get your questions answered and address your concerns around the criteria. But again, we're just trying to make this better, and we really appreciate your partnership in doing that. So thanks, everybody.